All right, well, we've got about 15 people online and more joining, so I think we should get underway. So my name's Nick Zwar. I'm Executive Dean, Health Science Medicine at Bond University, and I've only got a very small job to do tonight because others are doing all the hard work, and that's how I like it. So I'll maybe thanks everybody for joining, and maybe if we put up the slides, that'd be a great start. So yes, it's a great pleasure to be doing this online journal club in collaboration with UQ General Practice Research Network, and I'm shortly going to hand over to Professor Katharine Wallis, who's the main Professor of General Practice and head of the Primary Care General Practice Clinical Unit at University of Queensland, to introduce the panel and then take us from there. But first, I'd like to start by an acknowledgement of country. And in the spirit of reconciliation, we acknowledge the Kumpi people and the Turrbal and Yugara people, the traditional owners and custodians of land which GoldNet and UQGP research are based. We pay respects to elders past, present and emerging. And the impetus for this particular topic came from something I actually saw on GPs Down Under, where Associate Professor Geoff Spurling, who's one of our panelists, was commenting on this particular systematic review and how he'd reflected on it for his practice. So I think that's a nice example of how sometimes things can trigger an idea and then we can share it. So just a bit of housekeeping. Ali's keeping an eye on the chat, so feel free to make comments through the chat function. During the presentation, just if you could turn your microphone off so we don't get background noise if you're making trying to get dinner ready, or you're doing some other task, supervising the kids' homework or multitasking generally. But for the Q&A session, it'd be really great if people turn on your camera and microphone so it's more interactive when we have questions. So at this point, we'll move to the next slide, and I'll hand over to Professor Wallis, who'll take us through what we're going to do tonight.
Thanks, Nick. So firstly, I'd just like to introduce the panel. So we've got Associate Professor Geoff Spurling, and Geoff is a GP who works at the Southern Queensland Centre of Excellence in Aboriginal and Torres Strait Islander primary healthcare, and he also is an academic in the General Practice Clinical Unit with me at UQ. As Nick mentioned, this was a paper that sort of caught the attention of Geoff, and he'll be able to tell us about his journey and whether that made any difference to his practice or not. And it gives me great pleasure also to introduce Dr Anish Menon, who's a staff specialist at the PA, Department of Diabetes and Endocrinology. And Anish is also a research fellow at the Queensland Digital Health Centre at the Centre for Health Services Research at the University of Queensland. And hopefully very familiar with these drugs and how they're best used, and can help us discuss this sort of morass and what to add and when to add it. And also I'd like to introduce Assistant Professor Loe Albaquoni from the Institute of Evidence-Based Healthcare at Bond University. And Loe is well versed in these journal clubs and will be able to walk us carefully through this paper and help us make head or toe of it. So thank you all three of us for joining us tonight. And now I'd just like to set the scene a little bit by presenting a case. And this will give us something to think about as we go through the paper and think about, the appropriate treatment and what the next steps might be. So the case is a 74-year-old woman of European descent, and she's presenting for a repeat of her high blood pressure medications. She has no past history of cardiovascular disease. She's a non-smoker. Her father died of a heart attack, MI, at the age of 70, and he was an ex-smoker at the time. The patient, she has a BMI of 28, so she's a little bit overweight, and her blood pressure today is 130/80. She's currently on rosuvastatin, 40 milligrams daily, ramipril with a bit of a diuretic mixed in. And we decided to do some bloods on her as part of her sort of checkup and check on her cholesterol and HbA1c. So her HbA1c turns out to be a little bit high at 8.4, but her renal function is pretty good. And her cholesterol is not quite perfect, but she's already on the rosuvastatin. And so I recommend diet and exercise and start her on metformin. Just start slowly on 500 milligrams a day and increasing to maximum dose of 1 gram 3 times a day, and tell her to come back for a checkup in about 3 months. But she doesn't come back until 6 months. And at that time, she has had no change to her weight or her BMI or blood pressure. She's feeling fine. And when we repeat her bloods, her HbA1c turns out to be about 7.8. So it's got a little bit better. And when we calculate her cardiovascular disease risk, it turns out to be around about 10%. So I guess the question at that point is, what should we do? Is this HbA1c of 7.8 good enough? Should we try and get it lower? And if we do decide that, what should we do? What are the options? Should we change her from metformin to something else? Should we add in another drug? So I guess those are the questions to think about. And those are sort of guidelines that I've copied in of the RACGP guidelines, just to, if that was something you might go to in your practice. I think this was on page 56 or 57 or something like that of the guidelines. So you'd have to be fairly familiar with accessing the guidelines to be able to sort of quickly access that during your consultation. But this is what the RACGP guidelines are for management of diabetes. So they're saying first line is metformin. So we did the right thing first time up. Check her HbA1c in 3 months, which we tried to do, but she didn't come back until 6 months. And then they're recommending SGLT2I or DPP4I or sulfonylureas or the GLP-1RA. They're sort of depending on, with the cardiovascular disease risk, the cost factor, and the renal function. So does anyone have any questions at that point, just before we hand over to Loe to walk us through the paper? All right, I can't see any hands up anywhere. I hope I'm not missing anything, but perhaps over to you now, Loe, to talk us through the paper.
Thanks a lot, Catherine. So I'll share my screen. Is it coming with the screen? Yeah, sharing. So this is the article, and I have posted the link in the chat box. So as in the last few journal clubs, what we are going through this one, what's the key question that this article has addressed? And then we will go, what's the result? Whether the result valid or trustworthy. So kind of critical appraisal of the article briefly, and then discuss the results, the main results and finding of the study. And finally, we will hand over to the discussion about how that can inform the clinical practice. So just before going through this systematic review, because this is kind of a systematic review plus a network meta-analysis, not like a traditional pairwise meta-analysis, just briefly one slide about the network meta-analysis. So the usual meta-analysis, the pairwise, you have randomized trial, for example, this one comparing drug A head-to-head to drug B. That's called direct evidence. And you have another trial comparing drug B versus C. So that's the usual, combining those kind of trials together, that's the usual traditional meet. Sorry for that. But if we would like to know what's the relationship or association between drug A and C, where there is no direct evidence, then this is the network meta-analysis. So kind of extrapolating the evidence from A versus B and B versus C to know the association or the relationship between, or the effect comparing A versus C when there is no direct evidence. So the first question about what's the key question that the article has kind of addressed using the PICO or the BICO. What's the population, what's the intervention, the comparator or the control, and the outcomes. So anyone, what's the population that this trial addressed? In the chat box, or unmute yourself, please. So usually this information,
diabetes.
Yep. So usually this information could be in the abstract or the title, or in the method section, or in the last paragraph in the objective of the introduction. So in this one is adult with type 2 diabetes. So not children, not type 1 diabetes, only adult with type 2 diabetes. The intervention, as it's in the green, is drug treatment. So anything non-drug intervention is all excluded. So it's only drug treatment for diabetes. And the comparator is the standard treatment. And we will come to the definition of the standard treatment. And the outcomes, they have a bunch of the outcomes, but generally it's a kind of a benefits and harms. So again, here in the method section, a little bit more in more details. So the population is adult with type 2 diabetes, and the intervention is medical treatment, drug treatment, and these are the drug classes that they are kind of included. They have a long list in the article in the method section. And yeah, and the outcomes include cardiovascular deaths, all-cause mortality, and all kind of major cardiovascular events and other outcomes. So, all happy with the question? I think the main idea is try to find out whether that question is of interest to the patients that Katharine presented, whether that's kind of applicable or something not relevant.
Yeah, it's clear.
So the next thing we would like to know whether we can trust the evidence that have been addressed in this systematic review. And for that one, we have this kind of a mnemonic for doing this, whether this systematic review find all the relevant studies that have been addressing this question, whether they have critically appraised the evidence, whether they included the right type of studies, and then the totality and the heterogeneity. We'll come to each one point in separate. So the first one, did the search find all the relevant studies? So in this systematic review, whether they have done their job in finding all the available evidence, or the most of the available evidence that have been addressed, or try to answer this question. And for doing that, there are a few things that they have to do. First, searching a few major databases like Medline, Cochrane, MPACE, and whether they have used the right combination between the MISH terms, the index term, and the text word, free text word, whether they limited to English language, and whether they have used kind of citation analysis, or looked to the reference list of the included studies. So looking at the method section, and in this article, they have had that kind of a subheading. What do you think? Have they kind of met those kind of rule of thumb criteria? So maybe in page 6.
Looks good to me. They've searched 3 databases, used both text and mesh terms, and then done the forward and backward citation searching.
Yep.
Yeah, I thought it was good, except they threw out all the non-English ones. That's the only major concern, I guess, in that.
Yep.
Oh, right.
And the inclusion criteria, they only included English language studies. And so that's kind of a risk, could be like language bias. So that should be taken into consideration.
I thought that was interesting when lots of the authors were not from English speaking backgrounds, but English dominated nonetheless.
Yeah. So they have searched 3 databases, and here's kind of in the supplementary, they have those mesh terms, all those search strings. It seems like comprehensive. But again, the main thing is kind of the non-English language studies that have been excluded, which kind of can create one of the biases, language bias. But apart from that, they have, I think, did a reasonable job in finding the relevant studies.
What do you think, Luai, about the drug inclusion? So the search added terms for non-steroidal mineralocorticosteroid receptor antagonist and another one when they actually were interested in a big list of drugs.
I see. I think in the supplementary, there's a lot of search strategy. So a little bit complicated because this is an updated systematic review from a previous review. So in the search, in the supplementary, they have done the search multiple times. And this one is just the recent one. But I think in the other like search strings, they have all the terms for all the other classes. So I couldn't find any issues with the search strings, but I'm not information specialist, so could be. But generally, to me, it looks fine. It's just the main thing is the kind of the language issue. So that's for the finding. This next question, whether they have critically appraised the included studies. I think this is important because not all randomized trial, even if they included randomized trial only, but not all randomized trial are the same equality. So it's important to try to critically appraise the included studies and use that to inform the results. And that's also in the method section. They should make it clear, transparently record whether they have done risk of bias assessment, or sometimes call it quality assessment, and which tool they have used, and whether the tool is kind of the appropriate tool for this kind of study. So it should be also on page 6 as well. What do you think? Do you think they have done a reasonable job in assessing the risk of bias? Yep. So here they use the Cochrane risk of bias tool or modified version, which includes the kind of the main domains that could affect the quality of the randomized trials, and they follow the standard procedure for risk of bias assessment. So I feel it sounds kind of reasonable job in doing that. So that's the second one. The third one, whether they included the right type of studies and whether the eligibility criteria, the inclusion exclusion criteria, kind of clinically relevant or sound. So first they include, so this is a systematic review of an intervention for treatment question, and we expecting that they include only randomized trial, and that's what they have done. So only included randomized trial. And here's the eligibility criteria. So do you think any kind of any question or something you think that shouldn't be included, either intervention or population, in terms of intervention, population, or outcome?
I guess, Loe, I was interested, 24 weeks follow-up doesn't seem like very long to me in the scheme of things. But I mean, I know how difficult it is to get longer follow-up in trials and things, but I don't know what other people's thoughts are on that.
That's the minimum, Catherine. No, I agree. It's a pretty small minimum given that you're looking for mortality and cardiovascular events. But if there aren't many events within that 24-week trial, then it really doesn't add much to the meta-analysis. So mostly it's a way of cutting their work for not including anything shorter than that.
Yep, and also they did kind of a sensitivity analysis for only trials that have follow-up more than or equal 2 years. So that's only like longer-term follow-up duration.
This just exposes a little bugbear of mine, but drugs to treat adults with type 2 diabetes should really include antihypertensives and statins. But obviously, you wouldn't, that would just blow this review out of the park in terms of size. But it's almost like we forget those drugs as being like really important for type 2 diabetes. We only sort of think of these hypoglycemic drugs, but
right. You sound like you're channeling Rod Jackson there, who says that the treatment of diabetes is antihypertensive drugs.
Yeah, I don't know, Rod, but if you look at the sort of, there's this obsession with HbA1c, and which is quite, there's a danger in forgetting the vascular, the drugs that actually show significant reductions in mortality, which are the antihypertensives and statins.
Yeah, no, you're absolutely right, Jeff.
Yep, it makes sense to me that because their outcome, even most of their outcome, kind of cardiovascular outcomes, so that make more sense. Yep. So here more about the eligibility criteria and the outcome, and they define the outcome into critical and important outcome, kind of primary and secondary outcomes. And there's a long list of all the definitions of the outcome, if anyone interested. But mainly the outcome, the primary outcome, all-cause mortality, cardiovascular mortality, non-fatal stroke, and end-stage kidney disease and a mutation. So now the last two bits is the totality and heterogeneity. And another two kind of elements, especially in this network meta-analysis, something called transitivity or intransitivity, and coherence or incoherence, or the lack of coherence, lack of transitivity. So first, the totality up, it's important that they are kind of summing or pooling those kind of studies if it's appropriate, otherwise shouldn't kind of pull them together. And also they should measure the heterogeneity, which is the differences between the studies that they have assessed. And if there is high heterogeneity, they should explain that. But the other term that in network meta-analysis that they should also explore something called transitivity, which is kind of whether the population characteristic and the outcome and the intervention in the trials, in the direct evidence trial, is comparable or similar to those in the indirect. In another way, whether they can extrapolate the evidence from the direct, from the head-to-head comparison into the indirect evidence. Whether it makes sense, whether, for example, if all those have a head-to-head comparison, direct evidence, have a population in the older age group, but those hasn't measured the head-to-head comparison or the indirect evidence, the extrapolated evidence, all of them younger age group, it's not similar enough to extrapolate the evidence. So that's transitivity or intransitivity, lack of that similarity or exchangeability. It's kind of generalizability of the results, whether they can generalize the evidence from the direct evidence to the indirect evidence.
So if I understand you correctly, Loe, they seem to be generally younger people included in this work. So something like was it mean age of, I don't know, 57 or
50.
something like that? 50,
Yep.
was it?
Yeah, around the 50s, yeah.
And
Yeah.
yet, yeah.
So I think the main issue, whether that's different in the direct evidence, whether that's significantly different between the age, for example, in the direct evidence compare the indirect evidence. So that's kind of the question here in the transitivity. The coherence aspect is talking about whether there's consistency in the result in the direct evidence result. So for example, if there are so back to this graph, if there's A versus B, B versus C, and if there's some trials comparing A versus C, head-to-head comparison, whether the evidence from that direct evidence is consistent with the indirect evidence that they extrapolated. They kind of, whether what they found is similar to what they expect to found. That's, if they found that is similar, then they have kind of increased the confidence in the results. That's what they extrapolate is kind of true, or could reflect what they could found. So that's called coherence, or if that lack of that incoherence. So that's the two other things that we should look at. And they have lots of description here and also in the protocol about how they measured all those aspects. I'm not an expert in that, but what I could read is that it seems like that's the standard procedures. And looking at the list of the co-authors, it seems like they are kind of the pioneer in network meta-analysis. So, so this is kind of the heterogeneity, for example, they do it in multiple ways. The standard way using the I-square and the Cochrane-Q statistic, and they also measure that in a different way, especially for the indirect evidence. And they also looked at the coherence or the lack of coherence in terms of clinical and statistical significance. And they look at the transitivity, looking at the distribution of those potential important effect modifier like the baseline age, gender, body mass index, hemoglobin A1C, cardiovascular disease, the proportion of cardiovascular disease, and duration of diabetes.
Okay, I'm conscious of the time, Loe, so maybe we should move on to the results section.
Yep. So just in general, there is nothing like raising alarm in all of those things. And here's some of kind of result for all of those. So can we trust? I think we can trust, and we can move to the results. So that's a huge systematic review. So they included 816 studies, randomized trials. That's about 500,000 people, adult. The mean age in the late 50s, around 56, 57s. And here's a little bit of the baseline characteristic, as you can see, with the follow-up month duration. Age 57.7. And that's also similar to the hemoglobin A1C in your case, Katharine. I think 8.3 years. And the percentage around 60%, 2/3 of them have cardiovascular disease, and the mean duration of diabetes around 7 years. So that's for the baseline characteristic of the included trials and the participants within the trials. So the risk of bias, there's about 1/4 of them have a high risk of bias, at least in one of those 6 domains. Most of them due to lack of blinding. About 1/4 about missing outcome data and also the allocation concealment. So this is a graph called the network plot, where each of those kind of nodes is an intervention. And the larger that node mean, the larger the sample size that evaluating that intervention. And each line connecting those two intervention mean there's a head-to-head comparison. And the thicker the line, the larger the number of RCT.
Loe, just regarding this one, so standard treatments, I looked up and they said that was lifestyle advice and or sort of standard drug treatment, which they said was metformin and or sulfonylureas. So how does that work in here if you're comparing metformin to standard treatment, for example?
Yeah, I think that's one of the limitations, because this definition of standard treatment will be varied according to the trial. So for example, metformin versus standard treatment in this trial, the standard treatment will be the treatment that was standard in the trials comparing metformin versus standard treatment, which could be there's no treatment, will be other active treatment, because they excluded any trial with no treatment. There should be an active treatment, could be insulin or others. But for example, for the GLP-1 receptor agonist, because this is the recent trials, the standard treatment, I would say mostly will be metformin, because that will be the standard treatment at the conduct of the trial, at the time of the trial. So the standard treatment for each of those lines will be different, depend on the timing of the trial. But then the result, most of the result will be comparing each of those treatment or drug class compared to the standard treatment. And I think that's because of it's too complex. I think that's why it's not, they consider network meta-analysis not the best kind of study for clinicians, mostly for informing clinical practice guideline rather than clinician directly. So just because of the time, here's kind of the usual results for network meta-analysis, where for each of the outcome, they rank the treatment. What is the best or most effective treatment? So for example, here the dark green mean that's the most effective treatment with moderate or high certainty evidence. So I could say based on this review that SGLT2 inhibitors, GLP-1 receptor agonist, and non-steroidal mineral receptor antagonists are the most effective in reducing all-cause mortality compared to standard treatment. And we could say, for example, for non-fatal stroke, the GLP-1 receptor agonist is the only one that have high to moderate certainty evidence as the most effective treatment to reduce non-fatal stroke. But on the same time, all of those have the most effective treatment as GLT2 inhibitors, GLP-1 receptor agonist, and non-steroidal MRAs have a high to moderate certainty evidence as the most harmful, like the highest probability to increase the side effect or adverse events. And that's include for GLT inhibitors, genital infection, amputation, ketoacidosis. For GLP-1 receptor, that's severe gastrointestinal event, and hyperkalemia for non-steroidal MRAs. I hope that makes sense.
I like that. We probably do need to keep moving forward, Loe, don't we?
Yep. I think that's the kind of the relative effect, and also they present that in terms of absolute event, and they present something for the body weight change. I think I can stop here, and then we could come back to some of the results based on the discussion as well. Thanks, and sorry for being late.
Oh, no, not at all. That was very good, and a lot to make head or tail of there. So I might just open it up to the panel now. Geoff, do you want to provide some comments on that first of all?
Thanks, Katharine. So I guess the first lesson was to be careful about what you put on GPs Down Under. She might end up in a journal club. No, I found this paper like really exciting in terms of the promise of the new medications, and also hugely validating about the disappointment I felt growing up. So I entered this space in a meaningful way as a GP registrar back in around the year 2001, I think, when Paul Glasziou was still at the another community health centre general practice. And I think the available drugs on offer at the time were things like metformin and sulfonylureas and insulin, which are still the first-line things that the first-line drugs that the Australian Guide recommends, and that's all reflected in the PBS as well. It just felt a bit disappointing. And then along came this shiny new thing called rosiglitazone, which just happened to be really heavily promoted in our service. And it reduced HbA1c by a stunning 1%. And we'd all sort of, been heavily influenced by the UK PDS trial at the time, which was this massive study that said you must reduce HbA1c or everyone's feet are going to fall off and they're all going to go blind. Though actually, the mortality difference wasn't all that great for that study, and the macrovascular outcomes weren't all that great. But nonetheless, we're all really, I think, taken by this surrogate outcome of HbA1c, and I still think we are really taken by that surrogate outcome. And then it was really kind of confronting and I guess disappointing to see, and interesting, I guess, to see the results starting to come in about the effects on heart failure and heart failure admissions for that class of drugs. And how if a drug goes into the nucleus of a cell and does all these crazy things and reduces HbA1c, it can also have other deleterious effects. And so we've got to be really careful of this surrogate outcome. And I guess that's kind of been my sense right up until recently. So I've been like the next big thing that came along was insulin glargine. And so, we're all very enthusiastically prescribing insulin glargine, but people were putting on all this weight, and it just felt like this, okay, it was bringing their HbA1cs down, but it was making them tremendously unhappy because they're all getting bigger. And they really didn't like that. And it just seems so counterintuitive. And the only drug that wasn't doing all that was metformin. But again, it was kind of disappointing. Like it wasn't like you put people on metformin and then all of a sudden feel really great about what you're doing. Like, I mean, it's always been the accepted first line, but always a bit of a disappointing first line. So to have this study come out and basically say, and I've never really been all that enthusiastic about the gliptins either, the DPP4 inhibitors. Even though they also, but I guess I've always been skeptical of these drugs that come out and say they reduce HbA1c because I've been burned a few times. And then to have this study come out and say all those drugs are, pretty ordinary for reducing all-cause mortality, which is what we always talk about in our journal club, is just amazing. Like it was super validating. And then to see the new drugs coming on board with some admittedly scary side effects, including the amputation one I wasn't expecting. But they're helping people lose weight, and they're also reducing HbA1c, and they're reducing all-cause mortality. And suddenly, you've got some confidence that you might be prescribing some drugs in addition to the antihypertensives and statins that we've always had confidence prescribing in this space. That you might actually be making a difference for people. And it's interesting that it also improves quality of life in some of those metrics in the study as well. So yeah, I think the guidelines need updating. I think I'm not be interested to know what Anish thinks, because I know that many endocrinologists are still prescribing those first line drugs like sulfonylureas and insulin and things, but I've been taking people off them. And putting them on the new ones where as appropriate, obviously, because I'm still have a fair amount of skepticism back there, because I'm skeptical of all new drugs. I'm worried about what's going to come out. It's interesting that they seem to have more evidence for them than the older drugs. But a lot of that evidence can be tainted by drug company and company sponsorship and publication bias and things like that. So I'm not prescribing them willy-nilly, but it certainly feels like we're coming out of the era of sort of disappointment that I feel like I've been in, and going into one of promise and excitement for this patient of yours, Katharine.
Thanks, Geoff. And your sort of sense overall, do you have a sort of, I'm particularly, it seems to me the older people are they were the ones put on the sulfonylureas, and they're the ones that have a particular problem with hypoglycemia and that kind of issue.
I can go through my disappointment with my specific disappointments with each of those older drugs. But the sulfonylureas just struck me as the obvious one to strike off. I mean, they're almost tending towards increasing mortality in this study, in addition to causing weight gain and hypoglycemia of quite a magnitude. I mean, why would you prescribe them? There just seems to be no justification to me. And so I've been taking people off them when I see them on it. And because it seems worse than useless. I mean, the DPP4s seem useless to me. So I'm kind of like, meh, when I see someone on those, like I'm just not excited. And just seems like a waste. So I try and take people off those as well. And then insulin is the really interesting one, right? Like, I mean, obviously insulin was an incredible discovery for people with type 1 diabetes. And then you had the, all that DCCT trial and the importance of intensive control. So I can totally understand why we all thought insulin was an amazing idea, but it just doesn't seem like an amazing idea in this population. They inevitably put on weight and they feel terrible about that. And this study seems to confirm, that, it kind of validates my concern that maybe we're not really doing a lot of good with insulin in this population. So I've kind of, not unhappy about taking people off insulin either, which might be controversial, but I just don't see the benefit of it in this population.
All right. What we might do now is get the diabetologist to give his view on things. So perhaps over to you, Anish.
Thanks, Katharine, and thanks, Jeff. Interesting article. And of course, just to clarify a few things outset, I think these studies, most of these cardiovascular outcome studies and all the newer studies, or the studies with the newer agents have all been done on top of what is standard treatment. So to Jeff's point about hypertension, so yeah, all the landmark trials that is published in the NEJM or the Lancet, which I've gone through, is mostly where you have the RAS inhibitor, the RASi drugs or the statins on, and then you add these on top. So that is taken as standard treatment. Now, coming to the point about HbA1c, I agree, especially endocrinologists have been very glucose-centric, but I still think HbA1c has a great role in because it has been clearly shown that the HbA1c is linked to microvascular outcomes, and that has been shown unequivocally in both whether be it type 1 diabetes or type 2 diabetes. So there is that impressive reduction in microvascular to the tune of 20 to 30%. And then, of course, and that's very high quality evidence that we have for reducing microvascular complications. And then with regards to macrovascular complications, also that the evidence is not that great, but the observational studies, the follow-up of these, the DCCT and the UKPDS have shown the legacy effect in terms of the macrovascular outcomes being in the long term, showing better for the people who had better HbA1cs even at the beginning, even though the HbA1cs merged together later on. So on that aspect, I think we still have to be focusing on HbA1c, but I think that should not be the only thing. It can't be glucose-centric. It has to be all what was mentioned, hypertension, looking at the cholesterol, looking at other factors as well, lifestyle, diet. Now, coming to the actual, this one about Jeff's comment about sulfonylurea, I completely agree with sulfonylurea in the sense that I'm not a fan of sulfonylurea at all. And some of the things which has been even postulated is that the fact that the HbA1c lowering didn't actually show a mortality benefit could even in the shorter term could sometimes also people say been attributed to sulfonylureas, but no, that's a totally controversial topic. But to suggest that like the Australian guidelines haven't really the PBS hasn't been approving this mainly based on costs. So where possible, I don't use sulfonylureas, but there is still probably a role for people just for those microvascular complications where people are not willing to take an injectable or an insulin, and therefore we might have to put them on sulfonylurea to get them get their blood glucose levels down. Now, it is problematic in elderly individuals, as Katharine, you were mentioning, in terms of getting hypoglycemia. Now, coming to insulin, I think the same thing holds, although it does cause weight gain, but I think the main reason for one of the weight gains is also probably the issue of the high glycemic variability. That is where you have blood sugars going low and then having hypoglycemic attacks, then you correct the hypoglycemia, and then you have very high blood glucose readings, and those yo-yo phenomenon goes on, and that actually leads to more weight gain. Whereas if you really achieve the insulin, the optimal level of insulin, you probably are looking at weight gain around 2 to 3 kilograms, which is again not ideal. But yes, as Jeff pointed out, I think the trend has been to move away from sulfonylureas and insulin as first line, unless of course they come into a hospital with a blood sugar of 20 or 30, where you might give insulin just for helping them with the glucotoxicity, helping the beta cell recover some of their function, and it's kind of giving some rest to the pancreas, and which has been shown to be beneficial. So, and coming to the newer drugs, yes, I think as mentioned in this trial, and all the large scale studies point towards this as well, is that we need to now think diabetes not just as glucose-centric. We need to think about, okay, what are we really targeting here? It's not just glucose, but is this person overweight? Is this person obese? Is this person having cardiovascular risk? Is this person having problems with CKD? So based on that, I think is how the approach should be in terms of managing. Although the PBS restrictions don't allow us, but usually metformin is taken as standard because metformin does have some benefits. And then the second line would be, depending upon the risk factors, either a GLP-1 or SGLT2 inhibitors. That's been my practice. But having said that, I don't see most of these people. It's mostly in the primary care.
Yeah.
So
okay.
Yeah.
Thank you, Anish. That's very, very helpful. I'm just conscious of the time and wanting to finish 10 minutes before 7, but already past that. But I'm just wondering if there's anyone in the audience who would like to make any comments before we sort of perhaps look at going back to the case study and what the recommendations might be following this publication. Paul.
Just the one comment. I wanted to come back to Jeff's earlier comment about blood pressure lowering for diabetes, because to put it in context, the newer drugs are getting about a 10% cardiovascular and all-cause mortality reduction. That's about equivalent to a 5 millimeter reduction in blood pressure. Maybe 5 to 7 millimeter. But so I'm not saying not to use these drugs, but to keep in mind the blood pressure is probably a more important thing to control in terms of the cardiovascular. And for me, as Anish pointed out, it's the microvascular which you're not controlling through those means, and seems more important, a more important reason to try and get hemoglobin A1C under control.
And just to add, the semaglutide studies did show actually a 4 to 5 millimeter reduction in the systolic blood pressure.
All right, well, that is probably a good point to come back to the case. What should we do with this lady at 6 months who has got an HbA1c reduced from 8.4 to 7.8. Cardiovascular disease risk score on the new calculator, about 10%. So her current HbA1c, if we're interested in that, is 7.8. Her blood pressure's reasonably controlled. What should we do? Maybe Geoff, do you want to speak to that first? What would you do?
Well, I think I would put her on an SGLT2 next. I think if her renal function was okay.
Yeah, her renal function is okay. Yeah.
So assuming it's, I think 40 or 45 or something, it's got to be the threshold. But obviously you'd have a bit of a shared decision-making process about the harms and risks of SGLT2 inhibitors, and if she was okay with that, you'd go ahead. And just to clarify, despite my ranting about HbA1cs, I'm conscious of the importance of keeping your eyesight, not having your feet drop off, and keeping your kidneys and things. So it's not that I am not concerned about HbA1cs over 7%, but or 6%, but yeah, it's just concerned about it as a surrogate outcome, I guess. But yeah, SGLT2 would be my next one, but it's not actually it's not what the guidelines would say.
So Geoff, would you add that in, or would you?
Yes, I'd keep on metformin and add the SGLT2.
Yep. Okay. That's kind of what I thought too. After looking at that table that Loe drew our attention to, that seemed to be the most easy way to understand it. Does anybody else have a different view, or anything else to add there?
I might add there is that given that it's the cardiovascular risk that is the greatest here, and if this person, and the person is, the BMI was 28, a bit on the overweight side, I would be tempted to add, of course, it's an injectable. We don't have the oral GLP-1s available in Australia. So if this person was okay for their injectables, I would slightly prefer the GLP-1 receptor agonists over the SGLT2 inhibitors, given that they have the more stronger evidence in atherosclerotic cardiovascular disease, and also considering the fact that this person is also overweight.
It's a good point. Yep.
Yeah, I mean, I think it is a good point. The thing that I just have so much trouble getting hold of it at the moment. Got people who really obviously need it, and so that's kind of why I lean towards the one that I know they're going to get. Yeah,
that's right. Yeah, practically, I think it's right, because SGLT2, and also the fact is that it's oral. Most people would tend to prefer that over injectables.
All right, good advice. Take that with me to clinic on Friday. Thank you very much. So I think that brings us pretty much towards the end, and I'll hand over to Nick to thank everyone and close the evening.
Thanks, Katharine, and thanks to all the panel. It's interesting, for all of us who are on different guidelines groups, guidelines tend to provide quite a lot of options, and this is one, without always giving you a very clear assistance of which option to choose. So I think that was a really helpful discussion. So Ali, I think we've got a few slides just to close off, one or two, I think. So we'll talk. I think we've. So yeah, there's a few projects that are running through the various practice-based research networks, both through GoldNet and some through GoldNet research, and some through the UQ General Practice Research Network as well. One of the ones with GoldNet at the moment is the GP use of non-drug interventions, and everyone, of course, whichever network you're involved in, is very welcome to look at this. This is one from the Institute for Evidence-Based Healthcare, looking at barriers and facilitators' use of non-drug interventions. And many of you would know there's an RACGP handbook of non-drug interventions, which is on the RACGP website. So there's a QR code there for those who are adept with scanning QR codes, or it's also, of course, on the GoldNet website. The next one is one about, this is actually fairly recently been put up. It's about evaluating the feasibility of a digital program for secondary prevention of stroke. It's from people at CSIRO Monash, and they're looking to get a number of GPs across the country to participate in an online focus group. So this involves the Australian eHealth Research Centre. And again, there's a QR code. Next one. And then this is a study that Professor Wallis is leading, the RELEASE trial, redressing long-term antidepressant use in general practice. And this is about an intervention to help people to safely stop antidepressants and provides tapering protocols to help people get off those medicines, which otherwise for some people can be really quite hard to come off, but may not be providing much benefit for some patients. Okay, any more, Ali? And yes, there's the QR codes, probably the most important QR codes of the evening. To become a member, if you're not, of GoldNet or UQGP Research, again, with your digital skills, you can scan those QR codes and hear about the different events and things like the journal clubs, which the networks put on. And also for GoldNet, we have 2 face-to-face events a year here on the Gold Coast. One usually run at Bond University and one at Griffith University. And you can see there are all the organisations involved with GoldNet. It's Bond, including the Institute for Space Healthcare, Griffith University, Gold Coast PHN and General Practice Gold Coast. And Katharine would know if he's got partners at UQ, but I think you largely run your own show there. So I think that's it. We're 1 minute after 7, but we've done pretty well. Is there anything else I need to do, Ali, before we close?
No, nothing at this stage. There was a comment and a thank you from Dr. Wingham in the chat there, talking about behavioural change, whole foods and exercise, which of course I'm a big fan of, the whole foods in particular, being a dietitian. But yeah, non-drug interventions, obviously first line before medications, but important to, multiple approaches there.
Thanks for mentioning that. That was kind of a bit of a given today, but we haven't talked about. But obviously, as you rightly point out, and Dr. Wingham points out, those things are not only important to start with, but to continue as you're managing people with type 2 diabetes. So thanks, everyone. That's been fantastic. Let you get on with your evenings. And thanks, everyone, for participating and all our panelists and a really interesting discussion.
And to Loe for all the effort walking us through
yes,
that.
extraordinary. Yes, we
Thank you.
are in awe of your skills, Loe.
Oh,
Yeah.
Thank you so much, everyone.
Thanks, everyone.